Sure, sir. Very good evening. Myself, Dr. Kapil. I'm from Ahmedabad, Gujarat. And you have gone through the various talks yesterday, which were related to initiations, indications, contraindications, how we can start, which type of ECMO. So this is all. And today I'm going to talk about the ECMO related complications. So majority we divide into two types, machine related complications. So we call it as a mechanical complications. And second part of complications is type of it is a patient related complications. So I'll be discussing on the patient related complications today. I have no financial sponsorship for the disclosure. Objective of my talk will be, I'll be give a brief introductions how frequently we see this kind of incidences during our ECMO runs. What are the different types of the complications? What are the importance? How to manage it, and in which way we can prevent all these complications, which is related to ECMO. So we all know whenever we put the patients on ECMO, it is in the sickest patients of our ICU. And ECMO, patient is on ECMO, it's a blend of machines and the men. So one side we deal patient-related issues, and second side we deal with the machine-related issues. So if you know the underlying diseases and if you know the line of management, the outcome would be the better. Same way with the machines. If you are very well aware about the machineries and its components and the complications related to machineries, then the outcome definitely will be on the better sides. If you look into the incidence here, these slides I have collected from the ELSO. As we all know now, the ELSO is a patent registry of entire globe, and they had published this in 2024. So a few months prior, May 21, they had published these slides. So they started collecting data since 1990 to 2023, and they categorize all the patients in the neonates, pediatric, and the adult age group. As being an adult intensivist, I had collected specifically these slides where they had mentioned the adult respiratory complications. So the complications related to VV ECMO seen in the adult patients between 2019 to 2023. And if you see the patient-related complications, forget about the mechanical complications. I'm talking about the patient-related complications here mainly. So the hemorrhage stands at the higher rates, somewhere around 7 to 10% ratio of the hemorrhage is there. Then subsequently the clotting during the ECMO runs, neurological complications, as well as you can see the renal sites complications, cardiovascular complications, infections, and of course in the VA ECMO you see the limb ischemia also, and sometimes you require even an amputations during your ECMO runs if it is not managed, if it is not picked up timely and not managed wisely. Okay, so these are the brief about the incidences which we come across during our VV ECMO or the VE ECMO runs, complications related to patients. So as already mentioned, there are two various types, the mechanical complications and patient-related. Mechanical complications we are not going to cover in the lecture sessions, that we will touch particularly on the bedside, where you will come out at the RVMH. We'll explain you in details on the bedside as well as in real scenarios also on mannequins. And patient-related today I'm going to discuss. Of course, it depends on the types also. So if you see the complications list, there are certain complications which we see only in the VV ECMO runs, and there are certain complications we doesn't see during our VA ECMO runs. Suppose, for example, recirculations to be seen only in the venovenous ECMO runs. Other sides, differential hypoxemia, limb ischemia, cardiac stunnings. These are the complications we see during the VA ECMO runs. And of course, it will depend on the components used only. If you are aware about the different companies, their cones designs are different. The pumps which are there, the bearing pumps with the bearings and pump without the bearings. So the complications related to hemorrhagic like clotting and the chances of hemolysis are more with the bearings wala pumps, and without bearing there are less complications. So these are the different complications which are related to a component. So which component are you going to use? That also depends during our ECMO runs. So specifically in details, patient-related complications, there are list of complications which very well mentions in your textbooks also. So most common which we see is the hemorrhagic complications. The hemorrhage can occur anywhere, starting from the cannula sites to a CNS bleed or the GI bleed, retroperitoneal bleeds, if you are not punctured vessels properly. Second is hematological complications. Again, the second number we see is hemolysis. Hemolysis related to RBC lysis because of your prolonged ECMO runs. The cannula tubing size are small. You see this such complications. Of course, neurological complications. The commonest is CNS bleed. We see the CNS infarcts is also even with the heparin runs also. Seizures and brain death also occurs during ECMO runs. Cardiovasculars like arrhythmias. If there is a dyslipidemia, of course, there will be a arrhythmias. So these are the complications, systemic complications like hemorrhagic, neurovascular complications or cardiovascular complications, pulmonary complications. I'm not going to details in each of it because it will time will not permit me to cover all this, and it is very well mentioned in the textbook. So I'm going to cover only the particular certain complications which difficult to treat, not easy to identify, and if it is picked up timely, the outcome will be a very much favorable. So these are the list of different complications. As I had already mentioned, hemorrhagic complications very commonly seen, and the incidence, if you see, somewhere around 10 to 25%. It is morely seen, the observations is morely seen with the adults rather than the pediatric or the neonatal age group. Of course, it is very well described with the cardiac more on the respiratory, less in the respiratory, because here we puncture the arterial sites, as well as our ACT target will be higher side than the respiratory VV ECMO run. So the hemorrhagic will be more with the cardiac ECMO. The causes, if routinely we ask the questions to in our ICU or colleagues or during exams, everybody speaks the heparin is a culprit all the times. But I want to emphasize that heparin is only a culprit. It is not a cause. It can precipitate a hemorrhage, but if you have managed ACT and coagulation cascade properly and the dosage of the heparin is appropriate, or I mean to say any other anticoagulation like bivalodin, ergatroban, then they are not common a cause of your hemorrhage. The commonest cause of your hemorrhage is not properly puncture cannula sites. So if you are not punctured properly and the placement of your cannula is not proper, if you are not suture it properly. So these are the small things, but very important, because while or initiations, if you do a 3-4 arterial punctures, and at the end of 4th or 5th puncture, if you are able to cannulate it, then what about the punctures you have done already previously before cannulating it? So these are the things which create a issue related to hemorrhage rather than your heparin. Site, it could be anywhere starting from your cannula sites, so which is a obvious a compressible site, but sometimes we see a retroperitoneal hematoma, which is a very nasty things. Of course, again, I want to emphasize here is CNS bleed. All CNS bleed is not an absolute contraindications. If it is a type 1 bleed, so there is small hemorrhage, small SH, even then you can run a ECMO with that bleed also. And if we see the contusions or the trauma patients where we initiate the ECMO, the smaller minor bleeds are there. Yes, these are not absolute contraindications. You can do a ECMO run with the small hemorrhages. And if you're timely picked up, so cannula site monitoring is very important. Monitoring of hemodynamics like your pulse, which is very good guide. Immediately, if there is a small bleed, there will be no profound hypotension. It will start with the tachycardia. Then subsequently, if you are not managed it, there will be hypotensions. And subsequently, patients will require blood and blood transfusion according to your complete coagulations cascade. What are the general measures if you come across with the hemorrhagic complications is, of course, not first things is we have to decrease our ACT targets. Depending on our ACT, we have to reduce the heparin also. Not all the time to stop the heparin, mind it. Second thing, once we decrease the ACT target, again, if we are trying to treat one cause, second time we will create another enemy like clottings in the cannulas. So at the same times, whenever you decrease the ACT target, so means by you decreases the heparin dosage, at the same times you require to be increase the ECMO flow. So there will be less chances of the clotting inside the cannulas or the component of your ECMO circuit. Be ready with the new component, even with the sometimes entire circuits. Details evaluations is very important. Don't stick to your ACT or APT. Always ask about the complete coagulations cascade, which includes the PT, APTT. Don't forget to ask about the fibrinogens, CBC, plasma-free hemoglobins. And if you have luxury, you can ask for the TAG, ROTAM, and the sonoclot if it is available, depending on your institute practice. Optimization clotting factor, depending, give a root cause analysis. try to rectify it, and you can transfuse the blood and blood products. But important point here is, I think Dr. Indira Madam will mention in his lecture, is whenever you transfuse the platelet or the PCBs, all the time, remember you will require heparin slightly on the higher side, because your heparin requirement will be higher side. Of course, Nova 7, I prefer it is an relative contraindications, but if there are no choice, you can use very judiciously, very wisely, and local measures will always helpful to use compressions, take proper sutures. So these are just general measures related to your hemorrhages. Next is hemolysis. Again, the incidences is more in pediatric age group here as compared to adults. So what are the causes? Could be the hemolysis, because we all know there is a pump which will work like an peripheral heart. So the RBCs and blood component come in the contact with the pump and pump head. Same time with the tubings also. They try to hit with the walls of your tubings. So too much of hemolysis, if the flow is too high. If flow is appropriate, so ideal flow has to be there. If there is a continuous high pressure flow, definitely there are chances of hemolysis, RBC lysis there. So how we can pick up it? Very simple thing, always observe the color of the urine output, which is very important. If you collect the sample and if you notice the red serum, that is a bedside help. It will help you to pick up the hemolysis early. These are the early signs I'm talking about. And you can ask the cascades of the investigations like plasma-free hemoglobin, LDH. You can ask the bilirubins also. These are the parameters which will tell you about the hemolysis. And treatment, we all know, forced alkaline diuresis, treat the underlying cause. If there is a flow related issues, the RBCs lysis is there, then you have to optimize the ECMO flow, I mean to say RPM, revolutions per minute. So these are the measures how we can come across with the hemolysis. Now there are certain points which we should remember is dual circulations. So whenever there is an extracorporeal therapy, there are two circulations. One is your native circulations and extracorporeal circulation. Same things with the ECMO also. The native circulations is there as well as the extracorporeal circulations. The another term is continuous flow. As we all know, in our routine circulations, it is a pulsatile flow. So there is a systole and diastoles, which we call is the pulse pressure. So it is a pulsatile flow, where the ECMO flow is a constant flow, continuous flow, without the variations of the systole and diastoles. The next terminology is mixing cloud. That is a very well important terminology that I'll come later when we'll touch with the complications related to VA ECMO. So these are the terminology, if you remember, because whenever you read the textbooks, these are the terminology you will come across. So as we all know in VV ECMO, so first I'll discuss about the VV ECMO related complications. In the next chapter, next sessions, I'll discuss about the VA ECMO related complications. So in VV ECMO, complications, majority which we deal is the recirculations and RV failure. Okay, so what is recirculations? In the first configuration, you can see the femoral veins is there from where the blood is drawn, and it will return to your right IJV. Okay, so from the right IJV, oxygenated blood will enter into your RA, and from RA it will enter into the RV, and from RV it will enter into your systemic circulations. So this is the routine blood circulations of ECMO and VV ECMO which we see. But if it is not going that way, so now if it is not going that way, means the oxygenated blood which is returning from your IJV cannula, it is not entering into your systemic circulations, but it is sucked by your drainage cannula. Okay, so this the same oxygenated blood which are entering to the SVC, it's sucked by the IVCs. The terminology which we call it is an recirculations. Of course, the cannula, both cannulas are in venous lines, so there is some amount of recirculation which will be allowed. So up to a 30% amount of recirculations is going to be there. It doesn't require any treatment. But yes, if it is crosses more than that, it become a hazards and it become a complicated issues. The patients will become hypoxic because the oxygenated blood is not entering your systemic circulation. It's sucked by your drainage cannula. So the patient become hypoxic and SpO2 will go down. So which are the factors which are affecting the recirculations is pump speed. How it's affect? If the pump speed is very high, then there is too much of negative pressures on the tip of your drainage cannula. Okay, and same on the above one, your return cannula is there. So there are more of a negative pressures. The blood will be sucked from your drainage return cannula. So the pump speed is very important. Second thing is your catheter positions. At least 8 to 10 centimeter distance has to be there. So you have already the speaker was already mentioned in previous slide is your drainage cannula has to be at somewhere in the hepatic IVCs, and your return cannula in the jugular, which will be somewhere at the RA SVC junctions. If it is come closer, so either your drainage cannula is come down, come up, or the return cannula comes down. So the catheter position come closer. So because of the closer positions of both the cannula, the recirculations will take place. Third factor is your cardiac output. If your cardiac output is good, the circulations is good, and there will be no or very less chances of recirculations. But I'm talking about the tachycardia. What will happen if there will be a tachycardia? Not appropriate circulations will take place. Same thing occur with the AF with fast VR. When there is arterial fibrillations with fast ventricular rate, your tricuspid valve will not take proper opening times. So because of that, the recirculations take place. And the fourth thing is your RA size. When the tank is empty, okay, the patient is hypovolemic, what will happen? The drainage cannula will suck more of the blood from the RV as well as from the RA also. So these are the four more factors which take place during your ECMO runs and which precipitate a recirculations. Okay, so how will you notice or examine the patient's bedside or you evaluate for the recirculations is, first thumb rule is always there will be a desaturations. Okay, so the SpO2 goes down. Second thing, if you check if there is not too much of recirculations, what will happen? Both the cannula color will not same. So the initial stage or pre-oxygenated ABG, if you collect the ABG from the pre-oxygenated sites, your SpO2 or PO2 of the pre-oxygenated blood will be very high. Why? Because it sucked the entire oxygenated blood from your return cannula, and the pump pressure will be very pump speed will be very high, and at the same times your post-oxygenator or the venous side ABG will show the hypoxemia. And if it is too much of recirculations, both the cannula, return as well as the drainage cannula, both the same colors. So these are the clinical bedside practice, how we will evaluate the recirculations and how the pump speed will affect. It's very important graph here is, if you see the pump speed, if it gradually increases, okay, so you increase your RPM by 1000, 2000, same time, the flow will increases. Okay, so up to a certain marker, on the x-axis, there is a pump flow, and the y-axis, there is a effective flow. So on x-axis, if you increase the pump flow, at the same time, effective flow is gradually increasing up to a certain limit. After that, if you see the curve is coming down, so after increasing certain amount of pump flow, the effective flow become a plateau, and even after the certain limit, it goes down. So there is a chance, and if you see the recirculation ratio also, gradually from 0% to a 60-70% goes up. So always remember, if you see both the cannulas red color or patient is become a hypoxic sudden onset, what the bedside parameter, if you decrease the pump speed and if your SpO2 is increasing, that give you a good guide, and that is a click of a recirculations. Okay, so there is a formula also how we can calculate the recirculations. In my institute, what we do at the time of initiations, we do 3 ABGs. One is pre-oxygenated ABG, post-oxygenated ABG, and your venous sides ABG. We'll put these figures into this formula, and you will get how much oxygen, how much recirculations was there at the time of initiations. This will give you a good guide, because I had already mentioned certain amount of recirculations will be always allowed, and up to a 30% of recirculations will be there during your entire ECMO runs. So if you see the patient become hypoxic, again you draw 3 samples of blood from pre-oxygenator, post-oxygenator, and venous sites. If your recirculations curve is going gradually up, so that will give you the diagnosis of the recirculations. So how will you manage this? I already mentioned the first factor affecting is a pump speed. So if you decrease the pump speed by 6 to 8%, suppose your flow was 4 liter, if you make a flow of 3.5 or 3.6 liter during your VV ECMO runs, and if your SpO2 goes up, so SpO2 is improving, so that is a diagnosis of your recirculation. Second thing is your cannula positions. How we follow in our institute, we do a marking of the cannula where it is on the inguinal groin or in the IJV. Because why the cannula repositions occur? Because we give a head up positions, head down positions. While doing a X-ray, we make a patient's head up, and after certain ECMO runs, we even mobilize the patients out of bed. So there are chances of the repositioning of the cannula, and over the period of time, the suture which was fixed there is also loosened up. So these are the small things which require particular bedside monitoring daily. Will give you a good guide. If you see there is a bright red color coming from your drainage cannula, you'll pick up definitely it is in recirculations. So you have to reposition the cannulas. So don't jump in repositioning cannula straight away, give a head up or head down positions, because whenever you fix the positions, the some degree of the cannula will go away by times. Okay. So even despite of that, if the recirculations is not cured, then only we advise to always pull a drainage cannula out rather than the return cannula, because return cannula is too small insides. So if you are gradually withdrawing it, there are chances of certain holes which will be coming out, and there will be a messy things. So always first try to pull on the drainage cannula and then only the return cannula. Despite of all these measures, if you are untreat the underlying cause, like there is a AF with fast VR, hypokalemia, if you treat the arrhythmias, the recirculations will automatically will be treated. And despite of all these measures doesn't occur, then only the last solutions is to convert into from VA to VV-V or a VV-A. So from VV you have to make it in hybrid ECMO or the variant of the ECMO. Okay. So this is about the recirculations. Here you can see the colors. The first one is your always a drainage cannula, and return one is second is your return cannula. In first figure, if you see, there is a difference of color. So the cannula positions is appropriate and minor recirculations will be there. In second slides, if you see, the both the cannula colors are dark. So it is not a recirculations. It is, there might be some disconnections of your gas pipeline to your blender, or your venti is disconnected because of some oxygen connector is not proper. And the third thing, if you see, both the cannula's colors are bright red. This is your recirculations. Okay. Next complications during VV ECMO run, which we find across, is the right heart failure. Okay. So here right heart failure factor affecting the right heart failure, it is seen very lately. I had seen few of cases during our COVID ECMO runs, because we all know during COVID ECMO run, it was lasted for months also. So it has been seen in the third or fourth week. If you find the difficulty weaning a patient from your ECMO, you have to always look for the right heart. Ask the cardiologist to do a thorough echo. Ask them to check for the RV pressures also. So it is because of the persistent hypoxemia, and persistent hypoxemia may lead to a pulmonary hypertension, we all know. And there is a high flow pressure which are pertaining to your RA through the return cannula. So we routinely all know the RA pressure is somewhere around 5, and it is during prolonged ECMO run, 4 liter, 5 liter gush of blood is entering your RA. Over the period of time, RA and RV dilatations occur, and because of that, right heart failure take place. That is a echo findings, how the right side heart is becoming gradually enlarged. So we can identify easily during our ECMO runs. Clinical parameters, if you want to see, there will be hypotensions, there will be a high lactate, urine output will be low. So this picture mimics like an sepsis. So don't mix up it. You have to do a thorough examination. If you do a echo, that will give you always a good guide to differentiate it from the sepsis or the right heart failure. How we can manage? There will be hypotension, so the patient will require inotropic support. Treat the underlying cause. Definitely look at your antibiogram of ICU. Treat the underlying infections. If your lungs is persistently hypoxic and repeated consolidations is there, try to treat it with the higher antibiotics. If you see it, there is a RV pressure is going to high, mild to moderate, you can use the medical management like diuretics, digoxins, calcium channel blockers are there. If it is too high, then you will require a treatment like inhaled nitric oxide, which is routinely used in the pediatric practice. You can use the sildenafils also. And despite of all medical management, if you are not able to manage your right heart failure, then convert it from V to V-VA. So you have to put an additional return arterial cannula, and it will become a hybrid ECMO. Or you can use a protect DO cannula. I think it is very difficult to find in India. So the tip of drainage cannula will be in your RA, and return cannula will be in the pulmonary catheter. It is very difficult to even place it, not easy. But yes, these are the options theoretically available. Okay, now I'm going to touch about the complications which we come across during our VA ECMO runs. So here I'm going to touch about the three things. One is differential hypoxemia, then limb ischemia, and the cardiac stunning. So first I'll discuss about the differential hypoxia. So the point which I had mentioned previously, what is mixing cloud? So mixing cloud is nothing but where the mixtures occur of your both circulations. One, there'll be your native circulations, though the LV is ejecting flow towards the arch of aorta, and there will be again retrograde flow from the your return cannula in the femoral artery. So where the maximum clouds, so hypoxemia and hyperoxemic blood mixtures take place, the place which name it is a mixing cloud. Okay, so this figure will tell you if there is a cardiac stunning. So there is no cardiac activity, cardiac is standstill. So entire aorta is filled with the blood of the retrograde flow, which is coming from your femoral artery. So where properly oxygenated blood will be achieved by all the your coronaries as well as the branches which are coming from your arch of aorta. If there is some cardiac ejection, so what will happen? The blood will be ejected into your arch of aorta, but not reaching up to the branches of your the neck veins, neck arteries. So what will happen? The neck artery will be got the blood from your occipital blood, which is coming through your return cannula. If the cardiac conditions gradually improving, so mixing cloud will shift from initiations of arch towards the right brachiocephalic curve. So what will happen? Because you see the differential hypoxemia only and only when your cardiac conditions, cardiac contractility has been improving and your lungs are deteriorating. So the native circulations, native oxygenations will take place from your lungs, which are become damaged. So what will happen? Your coronary and the right brachiocephalic curve will get a hypoxemic blood. At the same times, your retrograde flow, which is coming from your femoral vein, it is a oxygenated blood. So two branches of your arch of aorta will get a oxygenated blood. So you see the upper part of the body will get a deoxygenated blood and the lower part of the body will get a oxygenated blood. So there is a difference between oxygen levels. Then the term comes alive, which called the differential hypoxemia. The other name of this term is Harlequin syndromes and the differential hypoxemia. Okay, so these are the two terminologies are there. So when the cardiac conditions improve and your lungs are getting deteriorated, so this is terminology which call is the differential hypoxemia. Okay, so how we can treat it? So what are the treatment? As I already mentioned, there is a cardiac contractility which increases. So what we can do? We can decrease the native circulations by decreasing the inotropic supports. Okay, but that is not a good option. Why? Because how if the contractions is around somewhere around 20% ejection fraction, so there are no drugs which can decrease the cardiac contractility. So this is not a very good choice. Second is increase the ECMO flow. Again, that is a not very good choice. Why? Because if you increase the ECMO flow, what will happen? The more blood, around 4 to 5 liters of blood will be gushed towards your aortic valves. So there are chances of aortic valve damage. So to treat the underlying causes, you will damage your aortic valves. Then the VA ECMO winning will be difficult. So the important point is here, improve the native circulations. How we can increase the native oxygenations is by improving the lung conditions. How you can improve the lung conditions? If the lungs are weak, you can increase the ventilatory settings. So optimize the ventilator settings. From mild ventilator setting, you can make it a moderate ventilator settings. So you increase the PEEP, you increase the some amount of FiO2 on the ventilators and treat the underlying lungs, why the lungs are deteriorated, whether any infections or any other conditions, treat the underlying cause. So these are the parameters how we can treat the differential hypoxemia. Even then, if you are not come across or the treatment, if you are not able to treat it, then again you have to convert it, because here what I had mentioned, the heart is improving and the lungs are deteriorating. So from VA you have to convert it from VA to V-VA. So you have to put an additional return cannula in your venous side. So you can puncture the IJV. So the occipital blood will enter into your systemic circulations, and then you can treat the differential hypoxemia. And gradually, if you see the cardiac conditions are improving, you can withdraw the arterial cannula also. The most important and the last point is change the cannulation strategy. What does mean by the change the cannulation strategy? By and large, what we do a femoral cannulation, femoral vein as well femoral artery. So the artery which we do a punctures is lying into your descending aorta. And we'll see the differential hypoxemia because of the upper part of the body. So if you puncture to start with the axillary or brachial artery, the tip of the return cannula which lies into your arch of aorta. Do you get my point? So there will be no differential hypoxemia, but provided it is very difficult to cannulate, there are chances of upper limb ischemia also. And if you change the patient's positions, there are chances of the tip will go into your descending aorta. Then there are chances of differential hypoxemia also. This is all about the differential hypoxemia. Next complication is limb ischemia. I am not going to in details is because we all know whenever we put a large cannula into your femoral artery, there are chances of low circulations in your distal limbs, and limbs get the ischemia. Of course, if you put a distal perfusion cannula also, even despite of that, because we put a 6 or 7 French of distal perfusion cannula, so sometimes it's get the block also. So these are the chances where you can find the limb ischemia. How you can treat? Always my mentor says, patient ke pair chune ke. If you chewing your patient's pair, you will identify the limbs is cold, clammy, and if you are not palpating pulse, there are the early pickup. You can check for the cannula block, distal perfusion cannula sites, whether it is block or kinked. So these are the clinical site we can picked up early. If you're not picked up properly and still the patient is getting no flow in your distal limbs, there will be chances of the gangrenes and you will require surgical interventions. Okay. Management, I had already mentioned, give appropriate flow, at least 150 ml per minute flow has to be there. If you find there is a small clot, you can flush it lines also intermittently. You can push some amount of heparin there also, elevate the limbs if you find there is a tightening of your limbs, and surgical consultations. Last from the VV ECMO convolutions is cardiac stunning. What is cardiac stunning? It is nothing but the complete or near complete absence of your ventricular contractions. So because LV is already poor ejecting, so if you are not treating on times, there are chances of cardiac getting a stunnings also. There are two different terminologies, stunning and hibernating. Stunning, it is a reversible conditions. If you are picked up early and it is seen in early stages. So when you initiate the VA ECMO in 6 to 8 hours up to 40, 50 hours, you can see the cardiac stunning. Later on, you can't see the cardiac stunning. And if you treat it on times, before the pulmonary edema occurs, if you treat it, it is a reversible conditions. Otherwise, if you see there is a pink fluid secretions coming out, the ET tube, if you have not taken a proper care, the 80% chances of mortality. So timely managed interventions and picked up will save a patient from cardiac stunning. And there will be don't apply the entire flow. So don't make it a non-pulsatile flow. Always prefer some pulsatility there. So pulse pressure, which is a difference between systole and diastole, has to be a more than 10. And sometimes because of the dyslipidemia. So there is a hyperkalemia or hypocalcemia, metabolic acidosis, lactic acidosis can cause cardiac stunning. So treat underlying dyslipidemia and acidosis. Avoid the reperfusion injuries. If your coronaries get hypoxemic blood, there are chances of cardiac stunning. So always give an appropriate ventilator setting so that your native circulations will take care of the coronaries hypoxia. And if it is an RV failure not treated on times, then it will ultimately convert into your LV failures also. So effect, I already mentioned, increase LA pressure, pulmonary edema, aortic valve closures. If it is not treated on times, there is a stagnant blood flow in your LV and there will be LV thrombus. It is a nightmare, and ventricular arrhythmia because of your LV stunnings. So what are the treatment? Of course, we'll try to manage it initially with the medical management, give much of bolus fluids if it is needed, start with the inotropic supports like adrenalines or the milrinones, try to keep a pulse pressures more than 10 at least, treat the underlying cause like hyperkalemia or hypomagnesemia or hypocalcemia or arrhythmias. They will take care of this. If it is not improving at all, what we do in Indian scenarios, we put always the IABP. So to improve the coronary perfusions also. And last resource is Impella is also available, but very costly thing. You can put even Impella during your ECMO runs also. And despite of all medical management or the minimal invasive methods which are not going to help you, then only one thing remains with the LV venting. Being an intensivist, I have never come across of LV venting. You will require your colleagues' help like CVTS or cardiologist help to do a septostomy and all, but it is a very messy thing. It's not easy to come out. Okay. So the take-home message here is meticulous bedside examinations and observation is very important. If you recognize them early, treat them early, the patients will always do better. Always do a root cause analysis and proper counselings to your family, patient's family. Thank you very much. I'm happy to take questions if you have.